Hi, this is Dr. Slazak. In this slide set, we will review available pharmacotherapy for osteoporosis in both men and women. This slide set will set the foundation for being able to choose appropriate individualized pharmacotherapy for patients. We will review appropriate use and efficacy, adverse effects, monitoring, and other clinical pearls that go along with these therapies. All of the agents we currently have for treatment and prevention of osteoporosis fall into one of two general categories. Most agents are anti-resorptive, meaning they decrease or slow bone resorption. Bisphosphonates, rank ligand inhibitors, estrogens, and estrogen-like products, as well as calcitonin, fall into this category. We also have one class of anabolic agents, or bone-building agents, the parathyroid hormone analogs. Just a quick review of pertinent pathophysiology with regard to bone remodeling. Remember that osteoclasts are responsible for bone resorption and osteoblasts for bone formation. Remember, think C for chew for osteoclasts and B for build for osteoblasts. And it is the tipping of the scales in favor of osteoclast action that leads to reduction in bone mass. Rank ligand is a key regulator for osteoclast differentiation, activation, and function, and osteoprotegerin, or OPG, is a decoy receptor for rank that is a natural inhibitor of rank ligand. Remember that the balance of all of these factors tends to favor bone loss in patients with advancing age and in females after menopause. We'll start our discussion of pharmacotherapy with bisphosphonates, as these are the most common and among the most effective treatments for osteoporosis. This is a list of the available bisphosphonates in the U.S. As far as brand names go, I've only included brand names specifically indicated for osteoporosis, not for other indications, such as use in patients with bone malignancies or metastases. The first three agents are oral and have extended dosing options, such as once weekly or once monthly dosing. Zoledronic acid is an IV formulation that is given once a year. As noted several slides ago, the mechanism of action of most osteoporosis therapies is inhibition of osteoclast function and thereby reduction in bone resorption. This is how the bisphosphonates work as well. Bisphosphonates are very poorly absorbed orally, with less than a 1% bioavailability when given to patients in a fasting state before breakfast. That absorption decreases to nearly nothing when given with or after breakfast, and decreases by 60% when given with juice, coffee, or milk. This is very important when it comes to counseling on proper administration of these drugs. Important to note is that the half-life of bisphosphonates exceeds 10 years, so this is going to come into play when we discuss the potential for drug holidays and also the potential for adverse effects. The most common side effects will be GI in nature, specifically due to the esophageal irritation that oral bisphosphonates can cause. These effects can be reduced by having patients remain upright for 30 to 60 minutes, depending on the drug, after administration. The IV formulation can cause a transient influenza-like illness. Rarely, oral bisphosphonates can cause GI perforation, ulceration, or bleeding. All of the preparations can cause musculoskeletal pain. Osteonecrosis of the jaw and atypical fractures are rare but serious side effects and are somewhat controversial. We'll discuss them separately on another slide. In terms of drug-drug and drug-food interactions, pretty much any drug, food, or beverage other than plain water will sharply decrease the absorption of oral bisphosphonates. Patients who cannot tolerate oral bisphosphonate therapy for one reason or another, be it adverse GI effects or the inability to remain upright after administration, can be transitioned to zoledronic acid, the IV preparation. In terms of oral bisphosphonates, patient counseling is extremely important in order to maximize effectiveness of the drug. For alendronate and risedronate, we want to take on an empty stomach first thing in the morning with 8 ounces of plain water. Wait at least 30 minutes before eating, drinking, or taking other medications, and remain upright for 30 minutes. For the delayed-release risedronate, available under the brand name Atelvia, we take with 4 ounces of plain water immediately after breakfast. Remain upright 30 to 60 minutes. Also, this drug needs to be swallowed whole. It contains a chelating agent that binds free divalent cations and may improve absorption. Ibandronate needs to be taken on an empty stomach first thing in the morning with 8 ounces of plain water and wait at least 60 minutes before eating, drinking, or taking other medications, and remain upright for 60 minutes. For zoledronic acid, we may pre-treat with acetaminophen to reduce the risk of acute influenza-like reactions like the arthralgia, headache, myalgia, and fever, which occur in about 32% of patients after the first dose, 7% after the second dose, and 3% after the third dose. We do need to watch kidney function for these agents, and we will discuss the appropriate length of therapy and the utility of bisphosphonate drug holidays in class. This slide on dosages you can read yourself. However, dosages are important, particularly when it comes to ensuring that patients receiving medications weekly, monthly, or annually are getting the appropriate dose at the appropriate time interval. I also want to point out that bisphosphonates are not recommended in patients with creatinine clearance less than 30 to 35 milliliters per minute, depending on the individual drug. We also want to avoid the oral bisphosphonates in patients with pre-existing esophageal issues and in patients unable to adhere to the appropriate administrative instructions. Now I want to devote a few minutes to talking about bisphosphonate-associated osteonecrosis of the jaw and atypical fractures, as concern over these particular side effects are one of the reasons we consider limiting the length of bisphosphonate therapy. Osteonecrosis of the jaw, or ONJ, is defined as exposed necrotic bone in the maxillofacial region, as you can see illustrated in this photograph. Risk factors for ONJ include invasive dental procedures, cancer, concomitant chemotherapy or corticosteroids, poor oral hygiene or ill-fitting dentures, or a variety of comorbid conditions including pre-existing dental or periodontal disease. The risk of ONJ may increase with duration of bisphosphonate therapy that exceeds 4 years and with use of IV bisphosphonates as opposed to oral bisphosphonates. The incidence of ONJ is small, occurring in less than 0.1% of patients without cancer who are taking oral bisphosphonates. That actually increases up to 12% in patients taking IV bisphosphonates, but for non-osteoporotic indications. It's also important to note that osteonecrosis of the jaw has been reported with other anti-resorptive therapies such as denosumab. The American Association of Maxillofacial Surgeons state that there's no evidence to support interrupting bisphosphonate therapy for routine tooth extraction. In patients treated for less than 4 years with no risk factors for ONJ, there's no need to delay any common dental procedures with the possible exception of dental implants. In patients treated for 4 or more years, or in patients treated for less than 4 years but who are also taking steroids or anti-angiogenic medication, a 2-month drug-free period is recommended prior to invasive dental procedures. This recommendation, however, is based on a theoretical benefit only. Keep in mind that because the half-lives of bisphosphonate are so long, you can argue that it wouldn't really be a benefit to temporarily stop the drug. Then lastly, it's recommended that patients who do develop ONJ should be seen by an oral surgeon and that bisphosphonate therapy discontinuation should be weighed against the benefit of continuation. Atypical femur fractures also have been reported in patients receiving bisphosphonate treatment for osteoporosis. The fractures are described as atypical because of their unique location and radiographic features, and they tend to occur in the subtrochanteric femur, which is the bone just below the hip joint, and in the diaphyseal femur, which is the long segment of the thigh bone. Some patients experience a prodromal pain weeks or months before the fracture occurs. The incidence here is also small, accounting for less than 1% of all hip and femoral fractures. It is important to note that atypical fractures have also been associated with denosumab therapy. It is unclear if bisphosphonate therapy is the cause for these fractures, although the majority of cases have been reported in patients who were taking bisphosphonates. Patients receiving long-term therapy greater than 3 to 5 years may be at increased risk. Bisphosphonate therapy should be discontinued in a patient who develops an atypical fracture. Next we have denosumab, or Prolia, which is a rank ligand inhibitor. Denosumab is a human monoclonal antibody that binds to rank ligand, thereby inhibiting osteoclast formation and decreasing bone resorption. So this is another anti-resorptive therapy. The dose is 60 milligrams sub-Q every 6 months by a healthcare professional. So this is not an agent that the patient's going to be administering at home. These side effects are specific to Prolia as opposed to a different brand of denosumab given to patients with bone metastases or hypercalcemia of malignancy. Commonly reported effects include back or extremity pain, musculoskeletal pain, and arthralgia, cystitis, and nasopharyngitis. Less common side effects include hypocalcemia, serious infection, dermatologic reactions, ONJ, and atypical fractures. Regarding serious infections, rank ligand is expressed on B and T lymphocytes and on lymph nodes. So a rank ligand inhibitor such as denosumab may increase the risk of infection. Some reported in clinical trials were serious infections in the abdomen, the urinary tract, the ear, and the skin. And in terms of the dermatological reactions, dermatitis, eczema, and rashes were seen, and those were most specific to the area surrounding the injection site. Denosumab may also cause hypocalcemia, so it's important that existing hypocalcemia is corrected prior to starting denosumab therapy. There's no well-documented drug interactions, and unlike bisphosphonates, bone loss is going to be rapid following discontinuation, so alternate agents need to be considered to maintain bone mineral density if denosumab is stopped. If you think back to pathophysiology and the changes in expression of rank and rank ligand and increase in osteoclast activity when estrogen levels decrease in postmenopausal women, it makes sense that estrogen would be an effective therapy for postmenopausal osteoporosis, right? However, due to concerns of adverse reactions associated with long-term use, estrogen and hormone replacement therapy fell out of favor as a first-line therapy for osteoporosis. But in the next few slides, we'll discuss raloxifene and conjugated estrogens plus beta-doxifene. So in that context, it's important to remember what the role is that estrogen plays as an anti-resorptive therapy. Raloxifene is a mixed estrogen agonist and antagonist and used to be known as a selective estrogen receptor modifier, or a SERM. Raloxifene is not estrogen, but it does act like estrogen in the bone, leading to its anti-resorptive effects. It's indicated for postmenopausal osteoporosis in females only. It carries an indication also for the reduction in the risk of invasive breast cancer in postmenopausal patients with osteoporosis. So that may be a unique subset of patients where this drug may be considered. Raloxifene, also known under the brand name Evista, is given at a dose of 60 milligrams by mouth once daily. Hot flashes are a common side effect of raloxifene, so use should probably be avoided in patients currently experiencing vasomotor symptoms of menopause, which you need to be cognizant of because these are generally postmenopausal females we're treating. Other common side effects of raloxifene are leg cramps, edema, and gallbladder disease. Raloxifene increases the risk of venous thromboembolism to a degree similar to that observed with estrogen, and therefore carries a black box warning. There is also a black box warning for increased risk of death due to stroke, as risk is increased in postmenopausal women with coronary heart disease or at increased risk for major coronary events. There is a recommendation to consider risk versus benefit in women at high risk for stroke. There's no significant drug interactions with raloxifene, but the use of systemic estrogen is not recommended while using raloxifene. Then we have a newer agent that combines both conjugated estrogens as well as an estrogen agonist-antagonist, beta-doxifene. This product is known under the brand name Duavi. It combines the estrogen and the beta-doxifene, which again is an estrogen mixed agonist-antagonist like raloxifene. The beta-doxifene component reduces the risk of endometrial hyperplasia that can occur with unopposed estrogen therapy. Therefore, progestins don't need to be taken with this drug. It is also intended only for postmenopausal women, and specifically women who still have a uterus. And like other estrogens, it should be used for the shortest duration, consistent with treatment goals and risks for an individual woman. When using this drug only for the prevention of osteoporosis, use should be limited to women at significant risk of osteoporosis and only after other non-estrogen containing products have been considered. And this product is available as a tablet with 0.45 milligrams of conjugated equine estrogen and 20 milligrams of basidoxifene, and it's given once daily. Here are the common side effects seen with Duavi, and it does also carry a black box warning similar to estrogens for risk of endometrial hyperplasia leading to endometrial cancer, risk of cardiovascular disease including VTE, risk of dementia with unopposed estrogen, and a warning to weigh risk versus benefit and use the lowest effective dose for the shortest duration, which is a warning carried by all estrogen products. The next product we'll talk about is salmon calcitonin. This is most commonly seen as a nasal spray known as Miacalcin or Fortical. It's also available as a sub-Q injection. The mechanism isn't well understood, but what we do know is that there are calcitonin receptors on osteoclasts and osteoblasts, and that injections of calcitonin cause a transient but marked inhibition of bone resorption. So this is still an anti-resorptive therapy. The nasal spray is administered as one spray to one nostril, alternating nostrils daily. This product is indicated for the treatment of osteoporosis in women only who are at least 5 years postmenopause, and it has not been shown to increase bone mineral density in early postmenopausal women. Also, it should only be considered in women who cannot or will not use other therapies for osteoporosis, as efficacy of this drug is inferior to the other products that are available. Common side effects include nasal symptoms such as rhinitis and epistaxis, as well as headache, arthralgia, and back pain. There's no drug-drug interactions observed with calcitonin use, and caution should be used in patients with an allergy to salmon. Lastly, we have the parathyroid hormone analogs. This class of medications are the only agents that stimulate osteoblast activity, leading to new bone formation, as opposed to all of the others which reduce bone resorption. So this is our anabolic therapy, our bone building therapy. These products are only indicated for up to 2 years due to a risk of osteosarcoma. They both carry a black box warning due to the increased risk of osteosarcoma in rats. Additionally, due to this concern, patients with an increased risk of osteosarcoma should not use these agents. This would include patients with Paget's disease, prior radiation to the skeleton, bone metastases, hypercalcemia, or a history of other skeletal malignancy. Similar to denosumab and the other non-bisphosphonate agents, bone loss may be rapid after these agents are stopped, and alternative agents should be considered upon discontinuation. And we'll talk about sequential therapy in class. Both of these medications are injected subcutaneously every day by the patient. Teriparatide or Forteo as 20 micrograms sub-Q once daily, and abaloparatide or Tymlos as 80 micrograms once daily. And Tymlos has only been on the market for a little over a year. The side effects are similar, though hyperuricemia is reported more commonly with abaloparatide, and leg cramps and musculoskeletal pain more commonly with teriparatide. Again, there are no clinically relevant drug interactions listed for either medication. And then to wrap up our discussion of available osteoporosis therapies, we have to discuss the relative efficacy of each of those therapies. So notably missing from this list is conjugated estrogens and basidoxifene. It has been shown effective at increasing bone mineral density, but we don't yet have fracture data available. So obviously the outcome of interest would be reduction in the incidence of osteoporotic fractures. Most studies divide these fractures into fracture reduction at the vertebra, at the hip, and then other non-vertebral fractures that combines fracture reduction at other sites and does usually include the hip as well as the wrist, forearm, and ankle. So notice that a lot of agents don't have proven reductions in hip fractures. They might have reductions in non-vertebral, but again, this combines multiple sites, so we can't isolate and extrapolate that effect to the hip. This is generally going to translate into which therapies are first line because the consequences of hip fractures are enormous. We'll review this slide again in class as well as put all of our treatment options together when we go through the guideline. Notably missing from this slide set is the role of calcium and vitamin D, but we'll also cover those in class. Thank you very much, and I will see you there.